Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody. I'm Dr. Vonda Wright. Thank you again for joining us on Hot for Your Health. And today, I am really excited about our guest because she is bringing to us a wealth of knowledge about a subject that there is such a knowledge gap in. So Dr. Corinne Menn is an OB-GYN doctor who is also a North American Menopause Society certified expert and works with Alloy as a consultant to help women all over the country, not only with their menopause journey, but in your case, really specifically answering questions for women in populations, subpopulations, who really have to fight for menopause care. So I'm so excited to have you here today.
Well, I'm so excited to be here. And I just love that we've got other medical specialties out there, like orthopedics, who's actually interested in talking to women to understand that your hormones and menopause affect every part of your body. So thank you for being someone who's not the menopause expert, who's promoting and understanding that it affects every subspecialty.
Oh, it absolutely does. And, I want you to tell my audience about your own story and specifically what you do for the women you serve. But in my office, the reason I'm doing this is, briefly in 2 seconds, at 40, I was in the best shape of my life. And I had just started a huge practice. At 47, I thought I was going to die. And I didn't know why, right? And at 57 now, I feel like I've kind of mastered this through self-education, talking with amazing people like you. But every single day, Corinne, can I call you Corinne?
Yes, please.
Every single day, women in the demographic that we serve come into my office with shoulder pain. And because I'll listen and take the time, women are weeping because they just want to be heard. They do not want to be gaslighted and told, which I say online, which really speaks to a lot of people. They say to me, I think I'm falling apart. And sometimes I think I'm crazy, which could never, it is so far from the truth. So that's why I have this passion within me. But talk to me about why you are so passionate about this, other than training in OB-GYN and the populations that you serve that are special.
Sure, of course. So basically, when I was 28 years old, I was a second-year OB-GYN resident. My mom, so this is 2001, another whole long story for another time, but my mom died pretty suddenly of ovarian cancer, and she was only 54. Wow. And so I was just trying to deal with that. At the same time, I felt a small lump in my breast. We had no breast cancer or ovarian cancer in our family history. And to make a long story short, 28 years old, diagnosed with ER/PR positive, HER2 negative, stage 2 breast cancer, newly married, like I said, in the middle of my OB-GYN training, starting to think about maybe wanting to have a baby, just seeing my peers. Yeah, just the normal life stuff. And I was now thrown into this cancer diagnosis. Yeah. So at the time, fast forward, I had bilateral mastectomy, multiple surgeries, reconstruction, chemotherapy. And due to my breast cancer treatments, which again, this would be an entire podcast in itself, but I went through early premature menopause 3 times, twice temporarily due to medication from chemotherapy, and then again from some ovarian suppression medication. And then finally, a number of years later, after I did have a healthy pregnancy after breast cancer, yes. I chose to have my ovaries taken out, not because I carried the gene, the BRCA1 or 2 gene. At the time, I was tested negative, and we'll get into that, how it's important to know about your genetic risks. But I just didn't feel something was right. I was like, my mom died of ovarian cancer. I had breast cancer at 28. Doesn't make sense. Something's wrong with my genes. Just take these ovaries out, plunge into surgical menopause. And you would think an OBGYN would know how to deal with that, but we got no training in my training. And when I was coming of age as a newly graduated OBGYN, it was around the time that the Women's Health Initiative, caused everyone to really fear estrogen and fear hormone therapy. So I think I, like a lot of OBGYNs, kind of then for the next 10 years, just I had all these ideas that were actually wrong about menopause, and I didn't have enough training. And I was really struggling personally and seeing more and more of patients in my office, with symptoms. And I said, oh, I've got to do something for me. And I certainly have to do something for the average woman. And at that point, I was like, I can't, nothing estrogen could come near me. Like I wasn't knowledgeable about a breast cancer survivor yet. But I can tell women that I've experienced most of what almost every woman, almost every experience that has been out there, I've actually experienced it, from early menopause to fertility concerns to, breast cancer, you name it. So, that's when I got involved in the Menopause Society, formerly known as NAMS, now the Menopause Society, and became certified and really just changed my practice to GYN only. And then since the pandemic, changed it to basically telehealth only. So I do a private practice in certain states for telehealth, but I also do just education consults throughout the country, and also work as a medical advisor and a prescriber on the Alloy platform, which is really trying to serve the general, kind of population of women who don't have access to menopause care and hormone therapy. So it's a real passion for me, because I have seen women at the most vulnerable. And you mentioned, like, who is the women that are really suffering? From anybody listening to your podcast, you talk a lot about how the average woman really is not getting educated on menopausal health and on, the true benefits of hormone therapy, and that she should be able to have that as an option. But if you have premature menopause, premature surgical menopause, if you have any comorbidities like endometriosis, in particular, certainly a high risk for breast cancer, family history of breast cancer, carrying a genetic mutation like a BRCA1 or 2 gene, women with perimenopausal mood changes and anxiety. Those are the women that I find are amongst the most vulnerable, and nobody wants to touch them. And they're really not only underserved, but they're misserved to the point of like medical malpractice, in my opinion.
Someone who write to me online, they'll make comments like, you are suggesting HRT. I can't do that because my doctor said my grandmother had breast cancer, or because cardiovascular disease runs in my family, or these completely non-data based just generalizations. And honestly, we live in a time of precision medicine, right? We sequenced the genome, 15, almost 20 years ago now. So there is no excuse for blanket medicine. And so I'm sure that's, in your daily consults,
yeah,
it is one woman's medicine, one woman's prescription.
100%.
Right.
But you bring up a point. The vast majority of women are not the most vulnerable that I mentioned, actually, right? So let's just talk about the average woman who doesn't have a particularly high risk of breast cancer. They haven't had breast cancer. And we'll get to that and address that. But most women wrongly think they're not candidates. So one, family history really doesn't have much to do with whether you could take hormone therapy.
Right.
That's one. It's much more about your family history is not you, number one. And even if there's a family history, I really can't think of anything in someone's family history that would preclude them. It may make us say, hey, for you, we may choose a certain formulation, like a transdermal over an oral, but even then, it really has to be individualized to the person. And this is where patients get the messages often from their primary care doctors or even their OBGYNs that, oh, no, not for you, because you are at a higher risk for either cardiovascular or breast cancer.
Right. Well, let's go down the road of the 25 studies. There was a meta-analysis that people quote a lot, and you have summarized it for me here. But I want you to summarize the data of the 20 reviews, the meta-analysis of 25 studies talking about breast cancer mortality and recurrence as it relates to HRT.
Yeah. So before I say that, I'm just going to just, for the general population, and this is like a statement that we have a preponderance of evidence, right? We know now that estrogen only, in the NWHI, women on their 20-year follow-up had a very significant, up to 30% decreased risk of ever getting breast cancer. Women who took an estrogen with a synthetic progestin, it was not actually statistically significant, but even if you want to think that it was less than one additional case for every 1,000 women taking hormone therapy, and it only applied to older women.
Over 70 women, 70-year-old women in the WHO.
Yes, only an older women. Yes, and at the North American Menopause Society conference this past fall, one of the top 10 things that they wanted us to know was that there was a recent study, Dr. Heather Hirsch actually presented it, that showed that formulation actually matters, and that when they look back at the data, that estrogen, no increased risk of breast cancer, estrogen with oral micronized progesterone, no increased risk, and then the estrogen with the progestin, well, you can quote the numbers from the WHI, which there's actually a paper coming out by Dr. Blooming in the fall, I think, where he's going to very clearly explain how and why the statistics of that were just wrong as well. So bottom line, what I tell patients is the preponderance of evidence tells us that hormone therapy does not further raise your risk of getting breast cancer. Okay. But now let's talk about what the question you asked me about breast cancer survivors. Okay. So the first thing is remember, this is not medical advice for any one breast cancer patient, but I do feel that women who are struggling with menopausal symptoms after breast cancer treatment, regardless of their estrogen receptor status, they need to understand that there is actually data out there, and that this idea of blanket statements that no, you can't have any discussion of hormone therapy, it's absolutely contraindicated, is actually wrong, oversimplifies, and just simply not true. So there is data, and it's not perfect data. All right, we're never going to have a perfect randomized controlled study anymore. It's expensive. It's not going to happen. But what we do have, we have a lot of data. We have over 25 studies that are done between 1980 and like 2013, 2014. And those studies, all but one, showed no increased risk of recurrence, no increased risk of mortality.
Yes.
And many of them show fewer breast cancer events, a decrease in mortality, and a decreased risk of distant metastasis. The exception is one single study. It's called the HABITS trial. And listen, I applaud all research, and I applaud this study being done. It was stopped early because they started to see an increased risk of recurrence. So everyone gets scared. It was published in the oncology literature. And so that's the one study that oncologists quote. But they don't take the time to actually explain the study and all of the data. So in the HABITS trial, so this is the one study that's preventing women from getting access to hormone therapy after breast cancer, it actually only showed an increase in either a new local recurrence just in your breast, or a contralateral, like a new primary in the other breast, say you didn't have a bilateral mastectomy. It never showed increased risk of distant metastasis, and it never showed an increase in mortality, even on the follow-up. So, and what was interesting, it showed no increased risk in estrogen receptor positive patients versus estrogen receptor negative patients. And women who had lymph node involvement had no increased risk.
That is interesting.
Well, because the biggest problem is that people were not randomized before they entered the study to whether they had a screening mammogram. It was not required. And all of the recurrence came in the first 2 years. And we know that breast cancer is probably subclinical for many years before it shows up. So to have just a local recurrence in the first 2 years in a population of women who nobody checked the mammogram before they even entered the study, many people find it actually disqualifies the results. And I don't want to say we have to completely disqualify the results, but let's see, what is this study actually saying? And what are the other studies saying? So when you have one outlier and then you have all these other studies, okay, 25 other studies, and then 20 review articles that went back and reanalyzed these studies, including the one that was most recently published in the Cancer Journal by Dr. Avram Blooming. If anybody wants that, they can message me. I'll get them the full copy of it, but you can look up at least the abstract, which just basically clearly lays out in a very nice scientific form. So if you want to bring that one article to your doctor, say like, well, actually, this is the evidence. Can you just read this 5-page article and have a discussion with me? So I think I always give patients that advice, like, look up this article, read the book Estrogen Matters, because it's written in a lovely way that's very easy for the layperson as well as the physician, to understand. But I saw oncologists, right? I was treated for breast cancer. They're very good about, well, they should be very good about they know how to explain risk versus benefits of, like, say, chemotherapy or mastectomy versus lumpectomy. So why, when we get to sexual health and menopause, can no one have a calm, shared decision-making discussion about what the available data is? And to say that there's no data is like literally not true. So it's very frustrating to me. And, it's just important, women should be treated for their primary breast cancer. And if that includes adjuvant endocrine therapies like tamoxifen or aromatase inhibitor, and you're in temporary menopause, that's okay. You have to do that, but we should address those symptoms as well. And so if there's a point in time where you can't use hormone therapy for your menopause symptoms, I'm here to tell you that we've got lots of guidelines that say we have non-hormonal options to treat your vasomotor symptoms. We can use vaginal hormones, vaginal estrogen in every single breast cancer survivor, no matter where they are in their treatment. So if you're being denied that, it's actually against guidelines. And then once you finish your primary treatment, then we can go and talk about, well, okay, for you, is hormone therapy an option or not? And, it's shared decision making.
So I think the thought of having for many women, this kind of discussion and asking the hard questions, maybe not hard questions, just continuing to ask the questions until they have an understanding, is a daunting task, right? I feel like it is hard for everybody to have that conversation with any doctor. You don't need to feel that way, but still there persists in that. I think something that women also don't realize is that there are resources like Alloy, who you work for, or work with. There are, frankly, first there was just one, as always, and now I can name 4 or 5 as resources where real doctors like you are on the end of the phone, who have the data at their fingertips. So I guess I'm saying this to the people listening is never stop until you get your questions answered. Because think about what you would do if your child were undergoing cancer treatment, or your child had an illness that you did not understand. I guarantee you would keep going and turning over rocks and calling and Googling best X disease doctor in the country for children. And yet I think many times women stop short for themselves, on top of the intimidation factor. So I just think there's a lot of, I think that's why, and I feel privileged that this happens, that women coming in to talk about their shoulder pain become so vulnerable to talk about all the rest of it. It's just because there is that kind of gap out there. So if you were advising people on, you got to know from the doctor you've known for 20 years, what are next steps besides bringing the article? I tell everybody to read Estrogen Matters. I wish I was an agent for that book. I read it. It's very easy. It was to change my life, actually.
Yeah. So I think there's a couple of things. I think that, one, you have to know that your doctors are probably as misinformed as you are. So it is, it's got to be a work in progress. And unfortunately, even in NAM certified menopause practitioner providers, once the word breast cancer survivor is mentioned, I'd say even most of them I have found really don't feel comfortable advising because they're really, I mean, the lack of knowledge of general menopause is so, it's terrible. And even amongst menopause providers, like it's like us breast cancer survivors, we've got like a scarlet letter around us. And so, ladies, it's a lot of work, but you're worth it, right? And so, there are some resources and we can link them at the end of this. And I keep them up on my LinkedIn, my link tree on my social media. So there's actually excellent guidelines. So I always want to tell breast cancer survivors, you got to think of it in maybe like 3 pools, right? You've got your vaginal and sexual concerns and accessing vaginal estrogen. That's an easy one, ladies.
That's right.
There's clear guidelines. I've got a document that I list literally. It's the links up there. It's a Google Doc that lists every society guideline and safety data saying, yes, you can have it. So if anybody's telling you no, if you're a breast cancer survivor, they're just wrong. That's easy. Low hanging fruit. Okay. Number 2 is your vasomotor symptoms. It's not just hot flashes and night sweats. It's lots of other things, mood changes, joint pains. You should make a full inventory of all of your symptoms and understand that that the gold standard really is hormone therapy, but we do have, non-hormonal options. North American Menopause Study just released a great non-hormonal position statement on how to treat vasomotor symptoms in a non-hormonal manner. So for someone who's in the middle of active treatment for breast cancer, or they're not being able to get access to hormone therapy because they're not finding doctors willing to talk to them about it, at the very least, you need to treat your vasomotor symptoms and your other menopausal symptoms because they are significantly impact your quality of life. So you can download that practice statement and the vaginal estrogen statement. And you need to find a place that does breast cancer survivorship because the impact of premature menopause and just menopause in general, but my focus is often on the even more younger, women like myself who went through early menopause. You have to be really hyper focused. And unfortunately, you have even more responsibility on good nutrition, lifestyle, strength training, and making sure you know your numbers. I say, know your bone density, know your lipid panels, right? Know your other chronic disease risks. And I think that's when you take those concerns and you list them and you make an appointment specifically to speak to your oncologist, not your just routine follow-up. They're busy, your GYN is busy. You make an appointment, say, I have it. I'll come in for a second appointment. I'll pay a second copay, but I'd like to come in and discuss this and be prepared. And I find the majority will at least listen if you are coming in an organized manner and respecting their time. And if they still are not helping you, like you said, you keep on fighting for more access. And I'd say NAMS is great. The other organization that's really great for trying to find a provider is ISHWISH, the International Society for the Study of Women's Sexual Health. Many of those sexual medicine experts are also quite competent in menopause, hormone therapy, and breast cancer survivorship. I've been very impressed by my colleagues that I through there. So that's really important. And always remember that surviving breast cancer, it's a marathon. It's not a race. Because 90% of women are going to survive their disease. Most breast cancer survivors die of something else, the number one being heart disease, right? Yes. So you have to think about big picture always. And you have to say to your oncologist, what is my risk of breast cancer recurrence? And what is the risk of the collateral damage that's happened to me either from my prior breast cancer treatments or my current breast cancer treatments? So another area that I'm super passionate about is that I don't feel that breast cancer patients who are either actively being treated for their breast cancer or had been treated in the past are actually truly counseled and informed on the true risks versus benefits of escalating adjuvant endocrine therapy. So understanding that when you have estrogen receptor positive breast cancer, we've got lots of different ways that we might target it from a hormonal standpoint. And for particularly the premenopausal patient, there's there's increasing degrees of kind of extreme hormone suppression. And a lot of women, I see it all the time. Women are treated with like a one size fits all approach, and they're given the most extreme and said, well, you're taking your risks if you just use tamoxifen versus an aromatase inhibitor, or, you know, change your doses or whatever. And people, when you actually lay out and say, do you know what benefit you're really getting from this? They're shocked how little it might be. Sometimes it's a big benefit depending on their cancer, but they need to be informed of that.
Implying that the risk-benefit ratio of taking a suppressive medication for a particular woman is actually very low based on her risk factors compared to, let me say that again. So the benefit she's going to get from the hormone suppression therapy is actually so low that the risks of other things, such as cardiovascular disease or osteoporosis, which I'm an orthopedic surgeon, and there are more hip fractures in this country than people with breast cancer, stroke, and cardiovascular disease. What you're saying is maybe if someone carefully examines the risk-benefit ratio, there might be an opening not to take those drugs, or to consider taking less stringent a suppressor. Is that what you're saying?
Yeah. And listen, this is where individualized medicine comes in. Breast cancer is really, it's a fascinating cancer because everybody's breast cancer is unique, like their fingerprint. So I can't make blanket advice for anyone. And within your breast cancer being different amongst each woman, your individual tolerance to risk, your risk tolerance, your risk of like the unknown and how you're going to feel from a psychological standpoint. Like, did I do everything versus I did what I thought I could tolerate? Like, everybody's going to have a different value system there. And I find in women's health in general, there's a lot of gatekeeping and a lot of still very paternalistic tones in. And I see this particularly in under-resourced, underserved women who maybe don't have as much education on this, women who don't have as much support in life, that they go in and they're told, you must do this. If you do this, you're a bad patient, you're non-compliant, forget you. I mean, I've literally had patients tell me that their oncologist has said, if you refuse this aromatase inhibitor or this, there's nothing else I could do for you. And it's just like simply not true, you know? And I'll give an example. So there's a recent study looking at lower dose called baby tamoxifen. So using only 5 milligrams of tamoxifen versus the full strength 20. And it was done in DCIS patients, so not invasive breast cancer. But it's the data is really powerful. It's showing that they get all of the benefits with basically none of the side effects. And that's great. And yes, that's for DCIS. Does it apply to a very low risk, low grade, low stage woman? I can't say that yet, but does that woman have a right to be informed that, hey, we've got this data on DCIS and you're having a really hard time with full dose tamoxifen. So, or some of these women are on aromatase inhibitors. I mean, I'm seeing patients who are like grade 1, stage 1, lymph node negative, tiny tumors, you know, saying you should be on this for, you know, aromatase inhibitor ovarian suppression for 10 years. No one's saying, but well, so I say to them, do you know what your benefit is? At 15 years, it's maybe 1%. Now, that's not the same benefit of someone who has much more advanced disease. And in those women, I'm going to counsel them like, hey, let me treat you non-hormonally for your hot flashes so that you can take this life-saving medication. So it has to be balanced by the patient. But patients are not being informed of all their risks and benefits and their options. You know, and it's really, I think, very paternalistic.
And I think them not being informed comes from several spheres. Because as a physician, I don't, want people walking away from this thinking, oh, doctors are evil. Let's go to whoever population of allied health people now treating women. But, sometimes it truly is the fact that only 25% of all allopathic or osteopathic doctors have been trained in menopause. So that's number one. Number two, it's being a doctor is like drinking from a fire hose, and being in a clinic is like drinking from a fire hose. And it's not for lack of desire. It's frankly for lack of time.
100%.
To address all these things. That's why patients who I take care of, they talk amongst themselves, because I'm a sports surgeon and that has been my career. And they'll say to each other, Dr. Wright expects us to be responsible. She is our partner. We are partners in this. One guy used the word culpability, meaning I expect my patients to be hand in hand with me, knowing what we're doing, knowing why we're doing it, doing what I tell them, this is how we're going to get better best. And so I feel like for women, that's the kind of responsibility I want them to feel, not blame. There's a difference between blame and responsibility. We're not saying women are to blame for any of this. We're saying, okay, starting here, we can take the power, take the responsibility. You're going to leave the listener is going to leave this podcast saying, oh my God, there's so much I have to learn from Dr. Menn. Where do I find her? And we'll tell you that. But keep digging, keep getting the information. If you need to hear her say the summary of the 25 studies and the 20 meta-analysis, then just rewind, right? Just keep searching. And that is a huge message I want women to get when they listen to things that I put out, is that you're, just like you said, I say you are worth the daily investment in your health, whether it's learning, whether it's lifting heavy weights all the time. But because I don't want women to ever stop with confusion and feeling hopeless walking out of a clinician's office.
Well, and then you can imagine that I think the average woman feels that way about a lot of things in health. And so when a breast cancer survivor is already then trained to manage all these other things, surgery, reconstruction, chemotherapy, hormone medications, sexual health, hair loss, I mean, the list goes on, and it doesn't end. So, for people who are, partners, family members, friends, remember the breast cancer survivor, it changes them forever. And this is something that's with them for the rest of their life. I will never technically be cured of breast cancer, right? Like that's like actually not a thing. Like it's true. Like the thing is like, we don't really know if my breast cancer will come back or not, right? Even early stage breast cancer can come back years later. Sadly, we see this. Olivia Newton-John, Suzanne Summers, it's come back. These are some celebrities you see, these are long-term, 15, 20 years later. So there always is a small increased risk for distant, recurrence and mortality. And so a breast cancer survivor may look like she's all back, her hair's back, she's got her reconstruction if she chose that or not, which is okay too. And she's moved on. But your people around it have to remember she's still dealing with the long-term collateral damage of treatments. We talked about the premature menopause, sexual, but also the premature menopause damage on cardiovascular, bone health, all those things. She's trying to manage all that. And so she may look happy, but inside it's still a struggle forever. And with this little chip on our shoulder that we always like, oh, is that little ache in my back a recurrence? Is that little, pain in my side? Oh, it must be a met to the liver. Is my brain fog that I'm having because of menopause brain mets? I mean,
that's right.
Any breast cancer survivor will tell you they have thought those things, and it never really goes away. So, like you're in this for the long haul as a breast cancer survivor, and those people around you have to understand that they've got to be there for you for the long haul. And why what you said is so important. If you don't invest in yourself, no one's going to step up and do it for you. And the oncologist won't either, not because they're bad. They're really busy. And the other reason why I think there's a reluctance of not only is it time, knowledge, but it's also our medical, legal system. OBGYNs are amongst the most sued doctors.
There is that. I want to expand
in the country. And so when you don't have time to properly explain the risks versus benefits, it's easier to just say, just suck it up. You're lucky that you're still alive, or, oh yeah, that happens to all women as they age, it's a little sex goes down and you get the hot flushes, just suck it up. I sucked it up myself. It's easier to say that, and it feels less medically, legally risky for them. And that's just the honest truth.
And that is the complete truth. I mean, in all of us, the litigiousness of every decision, I can't get away from it. And I still do the right thing every time, but it always is there. Yeah. But I had the opportunity coming up, and by the time this podcast is out, I will have done it, of speaking before a large group of doctors. And to the point you just said, I've queried the women I serve on social media about what doctors have said to them, because I'm going to quote back doctors. So all these things you just said, and I'm going to say in public, how dare you say that to a woman when there are 29 erectile dysfunction drugs, and you would no more say to a man, just suck it up, it's part of aging, there's nothing we can do. I'm sorry. There's all kinds of gadgets that have been developed. There are all drugs.
It's crazy. Yeah. So what I had a post recently about, premature surgical menopause. And it wasn't even about breast cancer survivors, right? Just premature surgical menopause. 1 in 8, let this sink in, everybody. 1 in 8 women in this country will have their ovaries removed for benign reasons prior to the age of natural menopause. So they're plunged into premature menopause, which we have a huge amount of data that tells us if you go through premature menopause, the earlier it is, the worse it is in terms of long-term impacts on your health. Higher all-cause mortality, huge increases in cardiovascular disease, dementia, osteoporosis. Everything we just talked about for general menopause, the risks going up. The premature surgical menopause, really high risks. But yeah, it was really interesting for the my board certification, American Board of OBGYN. They make us read articles, once a year for our recertification. So I was reading my articles, and I'm so happy that they have an article about this very issue. And so it's a new study that looked at the access of women to hormone therapy when they had premature surgical menopause. Less than 50% of women were offered it, which is the standard of care. They have to be. It's like if we took a thyroid out, we would want to replace it with thyroid hormone. If you take your ovaries out before natural menopause, you have to replace it. Less than 50 were even offered it. And the average length of time they took the hormones for was 5 months, because no one followed up with them and says, this is so important, or they just didn't give them access. So now back to your point about men. Imagine if 1 in 8 men in our country were getting their testicles removed every year for a benign reason that had nothing to do with any kind of hormones. Could you imagine them not being given testosterone? Well, it's the same. It's the same thing. Imagine every thyroid we took out. Imagine every thyroid we took out, we just didn't give thyroid hormone and just said, well, let's just see how you feel. Could you imagine that? But for some reason, it's completely acceptable. And most patients they tell me that even their GYN surgeons oh, we'll just see how you feel. I'm like, are you kidding?
Like it's an option. Like it's an optional organ system in our body. It's optional for you. It's only, you're not going to have any more babies. It's optional. Which, what? What? But you know what it brings to mind? And you deal with gynae, but I was interviewing a clinician who deals with uterine fibroids, and I was being told about the data, the socioeconomic data about who gets their uteruses taken out at a young age. It is underserved, socioeconomically low populations. I can only imagine that they too have more of their ovaries removed at the time of surgery. And so this becomes not even medical. It becomes socioeconomic. It becomes about access.
100%. And the most vulnerable women are often the ones who, they have the worst, So endometriosis, yes, can be highly, or fibroids. Listen, removing your uterus can really improve the quality of your life. And that's great. But guess what? Fibroid uterus endometriosis. Those are not contraindications to hormone therapy. Those women should wake up in the OR with an estradiol patch on their arm, a prescription for vaginal estrogen for life, period. So it's really it's really tragic, and it's a bigger problem than most people realize, because like you said, even for benign reasons, just taking out their uterus, many of them, they're in their like 40s. They're like, we'll just take your ovaries out at the same time. And no one talks to them. They're like, you're almost menopausal. We might as well just take them out. And that might be the right decision if you have a very high risk of ovarian cancer, or if you have a BRCA2, 1 or 2 mutation. But for the average woman, very few of them are educated that there's real risks to taking those ovaries out, even if it's close to the age of natural menopause. Your ovaries still function in postmenopause.
Right. Well, frankly, you're going to have to come back. And when we're on this ship in January, I think we should do long form 3-hour discussion.
Well, we're going to have so much fun. Yes, I have to update your listeners on that.
We're going to menopause expert, Dr. Mary Claire Haver has invited Dr. Menn and I and a couple other clinicians to join her as faculty on the very first Pause brand tour. So just like the celebrity women go on their makeup and clothes brand tours, we're going on a menopause brand tour aboard a cruise ship. So that is on Dr. Mary Claire Haver's website if you'd like to join us. But in closing, Corinne, you had several bottom lines that you just always want women to know, just like 1, 2, 3, 4, 5. If they know nothing else, what do they need to know as they go on their journey to get the best care surrounding this time in our lives?
Hormone therapy. Menopausal hormone therapy does not further increase your risk of breast cancer over your baseline risk. If you are a higher risk for breast cancer but have not had it, like you carry a BRCA mutation or other mutation, or you have a strong family history, you are still a candidate for hormone therapy. There's very good position statements from the Menopause Society that it is safe. Women who have premature menopause for any reason, whether benign or cancer, it's vital that you have your premature menopause addressed and treated, ideally with hormone therapy. All women should have access to vaginal estrogen at the first sign, or if they just want to prevent changes. And all women should know their risks for having a genetic predisposition for breast cancer. The Vassar Institute is a great place. There's a bunch of other resources we can list. So only 25% of women actually pursue genetic testing to see if they carry a genetic mutation. The reason why I want women to know that is that you can have your cake and eat it too. You can have your ovaries removed and even have increased breast surveillance, or even have a prophylactic mastectomy if that's what you choose. And regardless of your surgical decisions, you can still take hormone therapy. We have clear guidelines. So those are things that are often ignored. And I hope women, like you said, invest in themselves enough so that they can have their best life possible.
Absolutely. Well, thank you so much for all this wisdom. I'm still digesting everything you've said today, and I can't wait for people to listen and to re-listen and to re-listen to this podcast. So Dr. Menn, is found, I find her every day at Dr. Menn, OBGYN, at Instagram and all the places, and we will list where to find her and where to get a telemedicine appointment with you in the show notes. So thank you so much for joining us today.
Thank you for having me.
I'm Dr. Vonda Wright. See you next week.